That's great. Welcome, everyone. Can see lots of people trickling in from our waiting room as we get started for today. So we're going to jump right into things. We have a pretty packed set of questions and want to leave lots of time for conversation with our audience today. So just diving in, I'd like to welcome everyone to our CPE speaker series. As a very brief introduction to those who might be joining us for the first time, the Center for Practice Excellence is based out of the Leslie Dan Faculty of Pharmacy here at the University of Toronto, which is where I am today. And we focus on pharmacy education and training, research, and practice and innovation here at the CPE. Our monthly speaker series, which is where all of you are today, is really where we get to learn about and discuss critical issues impacting the future of healthcare and more specifically pharmacy. So just before we get started, I would like to start by acknowledging the land on which the University of Toronto operates, and as I mentioned, where I'm located today. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. I'd like to recognize that this meeting place is still home to many Indigenous people from across Turtle Island, and I'm very grateful to have the opportunity to work and learn on this land with all of you. Today, I'm very lucky to have Susan, Bev, and Natalie joining me for a discussion exploring how data, regulation, and strategy are shaping a pharmacy workforce planning across Canada. We will have about 30 minutes dedicated to some panel questions with Bev, Susan, and Natalie. And then we'll have the remaining 20 minutes or so for audience question and answer with everyone who's online with us today. Just for a few quick housekeeping items, I will just ask that you please put any comments or questions for any of our presenters into the chat. I will get to those at the end of our question set today, and I will moderate the questions that come in and sort of triage those accordingly. I'd also like to remind folks that many of our CPE sessions are recorded and posted on both our Faculty of Pharmacy website and then also the CPE YouTube channel. So just want to highlight that for folks. And my final little plug is if you can please keep yourself muted during the event today, but please feel free to have on your cameras. Love to see lots of familiar faces in the room with us. So just to jump right in, I would like to introduce our speakers. So I'll start with Susan. With a career in professional regulations spanning over 25 years, Susan James has been a pivotal force in the field, leveraging her prior background as a healthcare clinician, administrator, and lecturer. Since 2006, she has dedicated her expertise to the Ontario College of Pharmacists as the Director of Registration and Quality, where she oversees programs and teams responsible for the registration and quality assurance of registered pharmacy professionals, and also the accreditation and operational standards of pharmacies in community pharmacy, hospital, and drug preparation practice environments. Thank you, Susan, and welcome. Bev Zwicker is the CEO and Registrar of the Nova Scotia Pharmacy Regulator, NSPR, as well as the Chair of the Nova Scotia Prescription Monitoring Board. Bev has been instrumental in advancing regulatory modernization and aligning regulatory frameworks with public health needs and equity principles. Under her leadership, she's championed collaborative approaches to address healthcare system challenges, including the modernization and streamlining of licensure pathways for internationally educated pharmacists. Thanks, Bev, for joining us today. And Natalie Crown is an associate professor in the teaching stream, as well as the director of the Doctor of Pharmacy program here as well at the Leslie Dan Faculty of Pharmacy. Her research focuses on the health workforce and particularly planning, support, and retention of pharmacy professionals. In 2023, Natalie received a CIHR grant to investigate expansion of the pharmacy scope of practice in Canada, and she is also a co-investigator on a CIHR-funded project grant focusing on developing an integrated health workforce minimum data standard. Thanks, Natalie, for joining us. So just to kick things off, I'd like to start at a little bit of a high level and just ask each of you to share how you and your respective organizations are approaching health human resources planning in pharmacy and why workforce planning is especially critical at this time in this day and age. Susan, maybe I'll start with you.
Great. Thanks so much. And hello, everyone. And just to say, I'm excited to be a part of the conversation. I also do want to just start with a disclaimer. As much as I'm going to be talking from the perspective of a regulator, I am not speaking on behalf of OCPs. So I just want to be clear about that for all of the listeners. Okay, how are we approaching this? I guess I want to say I wish we had an HHR plan, and I think it's only fair to say that we don't have an actual formalized plan, but we certainly do have an approach. And I know that we're going to get into this. Part of the reason we perhaps don't have a plan is because we don't have what we need for a plan. We don't have the data. So our approach is very much pragmatic. It is experience informed. We have been doing this for a very long time. Anyone that is familiar with the work in Ontario, certainly for international pharmacy graduates, it has been many, many years that we've had significant folks coming into Ontario. And so it's an experienced, informed approach that way. We do certainly draw on the basic registration data that we have, and we do a lot of environmental scanning. And there is so much more that is coming out now than there ever was. So I think even to your second question or point there, why now? It's hard to imagine anyone that's not thinking about this now because it is everywhere when you're looking around. The escalation of issues is significant, but I also just want to point out that it's not new. And as I said, we've been at this. So the things that we're seeing and the drivers actually that we are seeing now that are pushing this forward, shortages within the workforce are not new. It's been over 30 years that we've known about these issues. We see them ebb and flow. And so while there certainly are many new factors, it's not a new thing. So just to say that it's important, it's out there, but it's been out there, and we've been focused on it for a long time.
Great. Thanks, Susan. Natalie, maybe I'll turn to you next.
Yeah, thanks, Annalise. Great to be here on this panel. I guess my interest in health workforce planning and specifically as it relates to pharmacy workforce comes from different lenses. I guess different lenses I bring to this work are first and foremost as a pharmacist, as an educator, as an academic leader, like in my role as the director of pharmacy of the PharmD program here, and now doing some research in this area. And so, I guess maybe putting on my educator hat. As the director of the PharmD program, we're really invested in the future success of our current students, and ensuring that they're prepared to practice to full scope, and we see how that is evolving, of their training, like within an integrated health system, right? So that's the educator hat. And why is it important? I mean, I think we'll talk about this throughout the hour, but it is sort of critical at this time, even though, as Susan said, it's not new, because as our profession continues to evolve and new scope is coming in different ways and different models of care, it's really important to us as like educators, as a professional, as a researcher, that we get it right? So here at U of T, we've made some changes to our PharmD program to better prepare our graduates to come into this new and evolving world of pharmacy practice. And some key pieces of that change are related to, our integrated accelerated curriculum with early exposure to practice and introducing programmatic assessment. So they're getting frequent opportunities on their progress as it relates both to like program outcomes and entry to practice competencies of what they'll need in to practice effectively in an integrated healthcare system. So that's the educator piece. And then the planning piece is critical, like from a professional or societal perspective, because of some of the data coming out, right? Like we have recent reports that show there's going to be shortages. These shortages are going to be exacerbated in the next 10 years because of an aging population and other factors in Canada. And so it is pretty critical that we better kind of the planning infrastructure in Canada, not just within pharmacy, but across the health sector. So.
Yeah, thanks, Natalie. I think that is critical as we think about, the future of our pharmacy workforce, and particularly people coming up through the PharmD pathway and pharmacy technician pathway, et cetera. Bev, I'll turn to you.
Hi, thanks. And like Susan, really looking forward to this conversation today. And I'm going to start with the why. The why for the Nova Scotia pharmacy regulator is pretty straightforward. We focus our work by reflecting on the question, what does the public need us to be doing so that the profession best supports them in realizing optimal health outcomes? And so for over a decade, we've been working so that pharmacists are able to bring the full extent of their healthcare professional degree, their knowledge and skills in both health prevention and health promotion, and of course, their expertise in medication to meeting the needs of patients in their communities. And we've made tremendous progress in that here in Nova Scotia. And the public and system leaders are experiencing the value of having pharmacists positioned in these community-based primary care roles. And particularly in our healthcare crisis, this is critically important. And where that has us is in a place where we need many, many, many more pharmacists in Nova Scotia. So this isn't about preparing for a pending shortage. We have a significant shortage. And so our approach then to addressing this issue is to collaborate with key system partners, the educators of pharmacists and pharmacy technicians, our Ministry of Health, our association, to better understand and monitor the supply and the demand, the evolving demand, so that we can strategize and hopefully get some synergy in our efforts. So for us as the pharmacy regulator, that has us looking at our licensing pathways and reviewing them with the intent that we fulfill our mandate, that we would license all who have the capacity to competently and ethically practice pharmacy in Nova Scotia and want to do so. And that has us looking to modernize our licensing pathway and incorporate the findings of research that shows how to alternative ways and maybe more effective ways for assuring that a healthcare professional is competent to practice in real life. And also to ensure that our modernized licensure pathways reflect the advanced pharmacy education that is happening globally and the advancements in pharmacy practice as well. So the curriculum and the education in pharmacy programs internationally that were in place 10 and 15 years ago, it's dramatically changed. There's been dramatic improvement, and we need to make sure that our licensing pathways for those outside of Canada reflect that.
Yeah, thanks, Bev. I think you touched on a number of points that we're going to get to in our discussion today, including the current shortage in Nova Scotia, and then thinking through approaches of what does that mean and what are other Canadian provinces and territories looking at. So thank you for that. I would like to circle back on something each of the three of you actually touched on, and that's the data. So Natalie, your research in this area and emerging research in this area is really showing that one of the biggest limitations to supporting planning, development, monitoring, and evaluation of health human resources is a lack of comprehensive and standardized data. So what we find, and Natalie, you point to this very nicely in one of your recent papers, is that data is actually quite siloed across educators, regulators, and others. And so I'm actually really curious to start there. What infrastructure and data systems are needed to really effectively support workforce planning and then perhaps by virtue of pharmacist mobility?
Yeah, big question, Annalise, and maybe I'll just point to some research that I'm not leading, but really happy to be working with a team of researchers at the Canadian Health Workforce Network as a co-investigator on a multi-year project that's really aimed at developing a fit for purpose integrated kind of minimum data standard. So the idea that you pointed to disconnected sources. And so ideally, across Canada, nationally, we would have a minimum data standard so that folks that could be harmonized, right, across all of health professions and healthcare workers. And so that's really a key deficiency, and you pointed this out in the current system, is that we have data that's fragmented because it's collected within single professions or single sets of within single jurisdictions, right? So it's breaking that down and defining what is that minimum data, like what should we know about all healthcare workers, related to their capacity to provide care to their full scope, where they work, their education and training, what they're trained to do, and demographic information, where they are, so that we move beyond head counts, to kind of have the right mix of healthcare workers, that local population needs. And to do that, you need data that's integrated, that's being collected. We're all collecting the same type of information, and it's accessible and shared. And so if you think about like pharmacy as a case study, like and like our own profession, right? From an educator perspective, we collect bits of data about our students as they come into our institution, but we don't necessarily have a very sophisticated way of even collecting all of that data nationally. And, the Caring for Canadians report highlighted this, that even when you're trying to get educational data, that data is hard to get, when they try to do some of these studies. And then, some of that data will go to a national licensing body for exams, for the national licensing exam. And then we have our provincial regulators that do a great job of standardizing some of the data they collect, but again, that's held provincially. So what we don't have in Canada for really pharmacy or any other professional is from the point of entering into a training program to retirement, continuous data about a healthcare professional. And so that's what we're trying to get to, with better workforce planning, and defining a minimum data standard is one way to start that process.
Yeah. Thanks, Natalie. I think that's such a key point. I really liked how you phrased it. It's really looking across the continuum of someone's, professional journey, but it's also sort of tied to their personal journey and perhaps, where life takes them along that road. So thanks for that context. Bev, wondering if you want to build off of any of Natalie's comments.
Sure. I think this builds off it, and certainly it reflects our experience. As I said, we're collaborating with our sector partners to monitor both supply and demand. And I think you need data on both current and projected demand and supply in order to do workforce planning. And you need big data, and it's not just data on the pharmacy sector. You need data on the full system. And in Nova Scotia, as the pharmacy regulator, we're working to get nimble access to this big data. Our government is creating a new data cloud, and it will enable us to have real-time access to routinely collected administrative data that we're hoping that we can analyze to answer the questions that we need to ask in order to truly understand demand and to understand supply, so that we create and support a healthcare system that is good for 2025 and onward. So questions like, what and where are the healthcare needs? And which health professional or group of professionals should those needs be allocated to?
Mm-hmm.
What is the capacity in each of those professions to meet those needs? What are the number of healthcare professionals, and where else could we find healthcare professionals, Canada and globally, and how do we strategize? So, there's a lot of really fundamental questions that we need to ask, but we need big data. Big data exists, and with new technology or new capability, I'm not going to say, I was going to say AI in this presentation, but here I am, using AI and the ability to do some impressive analytics, we can get there.
Great, thank you. I can see some nods from the videos that are on screen. Susan, I'll turn to you.
Yeah, I don't know that I have a whole lot more to say about it. I think certainly both Natalie and the things that Bev have said are very much the same for us. I think just truly that recognition that there isn't any one source of data. It's not any one of the organizations. It's not a province. It needs to be national. It needs to be even global in that sense, to some extent, because we need to understand what is happening that way, and what are the needs external to us. And I would agree, certainly, Natalie, your comments about, we need to determine what are those minimum data sets. Regulators certainly want to be a part of collecting the right information and not in a position to really determine what that's going to be. So I think just to say that when you talk about what's the model, it needs to be a coordinated model, and there are so many players that are a part of this. Who owns this in a way, or at least have we identified who the players are, and some recognition of coming together. I think that we're just not even there yet to identify the group, the source that comes together and has that common purpose, and there are multiple purposes. So we have a long way to go from our perspective in terms of really identifying how we can get the data, understand how to use it. And, Bev has touched on this as well. It is so much tied to the system, the scope of practice, what are the needs, and it's not even just within our own profession. That then ties into the healthcare system. And when I talk about the drivers that have been around for such a long time, it is very much related to scope, and what are other members of the healthcare team doing that are allowing for pharmacy professionals to expand their scope and move into other areas, maybe away from some areas because others are involved in that. So it's complicated. There are a lot of players that need to come together, and whatever that system is, it needs to be well coordinated, and everybody needs to be recognizing what their piece of the puzzle is.
Yeah, thanks, Susan. I think that's a really great point, and obviously very relevant for here in our Ontario context, as we're seeing some shifts with that scope of practice expansion in quite a short amount of time, I would say. So thank you for that. So I think I'd like for the next question just to zoom in a little closer on something that each of you also mentioned again, and that's about healthcare and workforce trends. And more specifically, I guess, as our Canadian population is really experiencing growing healthcare needs, and in many ways there's a huge healthcare crisis across Canada in many ways. Workforce planning becomes a lot more, Natalie, as you said, than about headcounts or about numbers, just purely looking at those sorts of things. It is also, as Bev mentioned, about public safety, and that's obviously a core mandate for regulatory bodies, and Susan and Bev on this call. So I guess with that in mind, I'm curious to get each of your thoughts on how Canada and our provinces should be thinking about pharmacy workforce trends, especially around supply and demand. And I guess building on top of that, I'm curious what strategic planning is helping to promote consistent care and safety for members of the public across Canada. Susan, perhaps I'll circle back to you to start off with this one.
Sure. This one's big. There's a lot to unpack in what you're talking about, and as I said, I think really a complex issue. I'm going to just pull out a few things, and I know that Natalie and Bev will expand on some of these things. But some of the comments that you've made there, workforce planning is more than the numbers, and we've already talked about. It is so hard to plan without the data. So I think just to put that out there, that as much as it's more, we do need to have that. That is a baseline that is making it very difficult not to have it, particularly recognizing it's both supply and demand. You've talked about, as regulators, it's for us about public safety, and that's our mandate. And so I do want to call out, and I don't know how many people know, but in Ontario, and all regulators have the public interest at play, and that's part of the college responsibility. The legislation that we work under is very clear. The college duty, there is a duty that is put right into the legislation that basically says we are required to work with the Minister of Health to ensure that in the public interest, people of Ontario have access to adequate numbers of qualified, skilled, competent, regulated health professionals. For us, that's pharmacists and pharmacy technicians. So there's a lot right in that. access to adequate numbers. So, what does that look like? That gets us back to supply and demand, and who determines that? How do we truly understand what is the supply and the demand, and what is an adequate supply? What does that look like? Is it government? There are so many factors that impact on that. Is it what government can agrees within in budget what they can afford in the healthcare system that healthcare professionals are able to provide in that regard? I was talking with a group today. Is it about businesses being able to define that? I live in an area that is not high density in terms of population. However, I can walk within a 1 kilometer radius to 14 pharmacies. Certainly other people can't do that, but we talk about how do we understand shortages sometimes. We know that there are shortages in certain areas, but what about distribution of some of the services? Do we need that? How do we establish that? Is it just a sort of open market and who can be available? I think for us, though, that we really then have to take a look at the adequate numbers of qualified, skilled, and competent regulated health professionals. And that's where we get into talking about the scope and understanding qualification and competency. And that's, Natalie, you talked about that at the beginning, about just the importance of making sure that as an educator that you understand what does that look like? Are you preparing individuals for what is necessary? Are they going to be qualified and competent, and that is what we're needing to understand together. It ties into scope. Who defines that? As I say, that's again, there are multiple players. Government in Ontario has been doing this, but they've been doing it in a piecemealed approach. I think Bev's going to be able to talk about an approach that is quite different and is in fact moving even faster. And so once again, we have a challenge across the country in that our scope of practice is far from consistent province to province. And as much as we eventually sort of get ourselves caught up, we don't see at any one point in time that it is consistent. And so the model, as much as we want to try to have qualifications and competencies that look the same, and we are all sort of driving to that, as the scope of practice varies from place to place, we know that we also have to be able to adjust that. And the needs within each province are different. The shortages that Nova Scotia is seeing, just the nature of our populations and the environments that we have in the different provinces. In a large province like Ontario, where even within the province, it's not consistent throughout the province in terms of what the needs are. So, you're sort of asking, what is it we need? I guess I'm saying that we need to understand that that there isn't any one answer. It is complex. We do have to be able to be flexible enough to understand what the needs are and how do we address those needs in the unique ways that folks require them. So, and also, I guess, just a reminder that in Canada, as much as we try to be consistent, our healthcare is provincial. So we certainly are impacted by government, and what is it that the government is going to move forward in that regard. And that's a lot of the reason that we have variation across the country, because the governments, while they also are trying to address their specific needs in the province, they have different beliefs and political policies that they are putting forward, and that's going to keep us different from place to place.
Yeah, thanks, Susan. Bev, maybe I'll go to you next, just for the other regulatory perspective here.
Oh, you're mixing up she's mixing up the agenda, guys. You don't know that. She's mixing it up. Yeah, I love the question. Workforce trends, how are the provinces? What was the question here?
Your favorite, Bob, how should we be thinking about supply and demand? And what does that mean?
Canada and its provinces be thinking about it? And I would reframe a little bit, like, what approach should they be taking to thinking about it? And what I would say, there's a lot being done, and I've seen being done around health workforce planning and recruitment. What I haven't seen being done is any foundational work of rethinking mental models people have about the various roles that healthcare professionals can and should play in a redesigned healthcare system that is going to meet the needs of healthcare of the population today and into the future, and not just Band-Aid, but how to better meet the needs to provide more quality care. And this is foundational work. I go to many conferences, many meetings. Everyone talks about the pyramids of system transformation, how that the foundational work to any meaningful system transformation is to rethink our assumptions, to challenge our mental models. And it doesn't go any farther than a slide at a conference. And then everyone launches into basically planning what workforce needs to be based on tweaks around the edges of our traditional healthcare system. So how the approach needs to change, we need to do that work that we all say is foundational to us really advancing and getting there. This is critical if we're going to understand the workforce that we need. We need to understand the roles that each profession is going to serve in order to understand how many that we need and where we need them. And so I would love to see that happen. I've been advocating it at every opportunity. And so I couldn't miss this opportunity to be on a national webinar and make a plug one more time. If anybody wants to see a great video about mental models, how important it is, Health Canada actually has a link, and I can send it to you, Annalise, to Dr. Alexis Lafontaine. I don't think I'm saying his name. Lafontaine does a great presentation on mental models. In terms of what we're doing to strategize how to ensure the public receives consistent care, I will say in Nova Scotia, we're using big data again so that we can ensure that pharmacies have the staffing that they need to effectively and safely meet the volume of healthcare needs that they're meeting. It's our StaffWise project, so that's an important work that we're doing. And then again, we're also working with our, continuing to work with our system partners to demonstrate through, like there are community pharmacy primary care clinics here where pharmacists are in primary care and demonstrating these are the needs of healthcare that pharmacists can meet, should meet. Here are the better health outcomes that are being realized. And where we are now, the next bit of strategy that we're going to be working on is to address a problem, an in-house problem, if you will. So we have our external challenge of helping system leaders and others understand the role of pharmacists when they're practicing to the fullest extent. We need a lot of work to do internally in the profession to help pharmacists and pharmacy technicians understand that full role and why they need to step into that full role. And that is important work we're going to need to do if the public is going to be able to consistently experience from pharmacy to pharmacy, from pharmacist to pharmacist, the care that we're saying that we're promoting and saying can and should be provided and is at some pharmacies. It needs to be a consistent experience.
Yeah. Thanks, Bev, for those remarks. I'm going to just transition. Natalie, I don't know if you have any comments you'd like to add to what Susan and Bev have commented on.
You know what, Annalise, you can go on into, I think it'll come up next. Yeah.
Yeah,
Go
for
ahead.
sure.
Yeah.
We'll carry on, and then I'll just do a quick plug now for our audience. If
Yeah.
you are starting to have questions, thoughts, comments, please put those in the chat. I can see Katrina, thanks for contributing one question that we'll get to. But just to transition to the final question that we sort of had our panel here to discuss today. And this was really prompted by quite a few audience questions that were submitted prior to the event, which was fantastic, is around some licensure. So as I mentioned with the previous question, it's no surprise to anyone that our healthcare system is under immense strain. And the corollary to that, I guess, is that pharmacists, as we know, are one of the most accessible healthcare providers. And so with ongoing discussions, and this has been an interesting topic for me to learn more about recently, around national licensure and harmonized scopes of practice, I'd like to hear your perspectives on what are the key opportunities and also challenges of national versus provincial or territorial licensure for pharmacists and pharmacy technicians, and how might each approach, so national or provincial and territorial, influence pharmacists' scope of practice and role in our current healthcare crisis. So Bev, I'm going to flip back to you to get us started with this question.
Great. You've heard me on this one, so I'm going to stand on my soapbox. Now more than ever, we need innovation. We need to rethink and redesign how we are providing timely and quality care to in communities. We need to rethink how we are assuring the competence of individuals who are applying for licensures, how we are assuring the ongoing competence of those who hold a professional license. And in most provinces, these kinds of changes and redesign require regulatory changes. They require convincing system leaders, policy decision makers that this is what needs to happen. And the reality is that we live in a huge country, and philosophies, priorities, personalities vary across the country. And a nationally harmonized scope of practice, national licensing requirements, would require us securing national agreement across all of the provinces. And the common ground that we could all achieve would not be the most progressive scope of practice. It would not be the most progressive licensure pathway. The authors of our Constitution correctly determined that the best approach is to have the provinces determine for themselves how healthcare will be delivered. So that's authority that resides at the provincial level, and hence how the healthcare professions are governed. National licensing requirements, a national scope of practice would actually undermine opportunities that currently exist for provinces to innovate and to demonstrate the safety and value of that innovation in their own province and to the rest of Canada, so that others can learn and do likewise. Every area has a different priority, and so we've benefited from some of the innovation that's happened in British Columbia around treating opioid use addiction and how to achieve reconciliation with First Nations people. Ontario's done some great work in innovating around assessment of competence and practice with their PACE program, and it's helping to inform our systems. And in Nova Scotia, we've had a regulatory sandbox that we've been able to use and been able to explore pharmacists in their very fullest healthcare provider role in communities, and most recently through the community pharmacy primary care clinics. And now we're going to be scaling that up so that all pharmacists in the province can provide the very fullest extent of meet the fullest extent of healthcare needs that their knowledge and education supports. And we're also modernizing our licensing pathways, and the other provinces will benefit from that. So for me, I know there's there's a instinctive thought that, oh, we just need a national harmonization because everyone believes that way we'll all be at the top. The fact of the matter is, harmonization would put us all probably somewhere around the 20% mark, not the 100% mark. Susan and others, I don't know if any more you want to say on that.
Yeah, maybe before we move on, Bev, I'd love for you to explain just the concept of the regulatory sandbox approach in Nova Scotia, because I think it's quite innovative, and I don't know if everyone on the call today knows about it.
Yeah, so a regulatory sandbox really allows for sort of some close supervision for new things to happen. So as a regulator, we need to make sure that practice is safe, the public is protected. And so when we authorize activities for the general population, the safeguards are different, and it's the evidence that we need is pretty robust. But in order to generate evidence to substantiate that new activities are safe and bring value, we need a way to add maybe some additional safeguards while allowing broader activities. And so our regulatory sandbox that we have is allowing pharmacists who are enrolled in a research ethics board approved project, or a project that's been established with our Department of Health, to engage in new broad activities that we have closer scrutiny on. We put in some additional monitoring, and from there we learn from that and then use that to inform policy decisions for scale up. So HIV PrEP is one clinical activity that was recently studied and now has been scaled up. Pharmacists are able to prescribe for HIV PrEP in Nova Scotia, and more substantially, again, is our community pharmacy primary care clinics, where really the extent, and I don't want to be letting the cat out of the bag too early, but over the next 12 months, we will be reworking our, redesigning and updating our approach to pharmacists, and how, and the standards and the direction, if you will, and the guardrails that we put up around pharmacists practicing to their full scope of practice, and adopting a standard of care approach, which is really the definition of the scope of practice then is any activity that is supported by a pharmacist's knowledge and skills.
Yeah, thanks for dangling that carrot, Bev. Sounds like there's some
Stay
good work and a
tuned for
good
the
follow-up.
stay tuned for more on that. Yeah.
Susan, maybe I will turn to you next on this question.
Sure. And I think just to follow up a little bit with what Bev has said, she's talked about some of those opportunities. I think it's so important to understand that there is great opportunity in the various provinces who will often have a lead in a particular area that might be a focus because of the things that are going on in that particular province. And so just to really echo, as she said, that provides for great opportunity. And what happens within one regulating organization, one province, often is something that we start to see coming across, into other regulators. We learn from that. We are able to draw on the experience, the evidence, and it's very helpful. Our governments look to that, and the governments across the country certainly come together and understand what's going on in other provinces. And that's why, I said earlier, I think eventually we start to see that over time we get closer and closer, yet there's always new innovations that are happening as well, and they are sometimes in different paces. And I think you've got a regulator here from a province that is small, certainly compared to ours, where we are so large. And I think the opportunity sometimes in a smaller place to be a little bit more nimble and to be informed in a different way. For Ontario, the size can be a challenge. It is a barrier sometimes, and really does hold us back from being able to move as quickly. Yet when there is something that is large and significant here, and we have to act on it, then we have that benefit of being able to demonstrate that in sort of a full out opportunity of implementation that sometimes, because it is that large, it also lends itself to others being able to draw on that experience. So, the pros and cons of that, and as Bev has said, I would fully support that it's not about us having to be consistent at the same time, but knowing that we are working together. And I do think that, it's not just the regulators, but pharmacy as a profession in Canada does a very good job of coming together nationally, whether that's the educators, the regulators, the associations that really are working. We probably could do a better job of all of us working as organizations towards some of the data and understanding this, making sure that we are having these dialogues. This is a great example of the kind of conversation that we want to make sure we're having together, because we are all a part of it and of course impacted by it. But to try to think that we could do that as one organization, one licensure model, I think that there would be more to lose than to gain.
Yeah, thanks for those thoughts, Susan. And Natalie, I'd like to turn to you.
Thanks, Annalise. I mean, a couple of thoughts. just coming from some of our research in this area that relate to this particular question of scope and licensure. I guess, yeah, I agree with Bev that like harmonization of scope, or I think what you said, Bev, like, it's a nice idea as long as it's not the bottom 20% of scope. And in some of our research where we interviewed pharmacists in different Canadian provinces who were at, like, we interviewed pharmacists in Nova Scotia, Ontario, and British Columbia, with various scopes, in phases of implementing new scopes. One of the things that came out in those interviews is related to the idea of accessibility. And you know pharmacists in our study did articulate that they have an understanding of health needs, of regional health needs. And so that's something that I think needs to be taken into consideration when we talk about harmonization of scope and national licensure, is can't lose touch of regional needs and that those are different, right? So, a pharmacist practicing in rural Nova Scotia would give examples of, the need for chronic disease management in people without access to primary care in an older population. And that's quite different than a pharmacist practicing in an urban environment who may be, utilizing scope to deliver care to diverse populations, newcomers to Canada, like harm reduction and other things that the panelists have mentioned. So the preparation for full scope has to take into account regional needs. And in our work, we saw that come through, and also this idea that people have largely embraced this, like in our cohort at least, as part of their professional identity. In other words, pharmacists see themselves as being able to provide those services, through prescribing and other full scope services to those populations. And so I think those are a couple of things that relate, from our research, that relate to the idea, to the scope conversation, harmonization, and licensure.
Yeah,
And
thanks so
maybe
much.
one last thing, like Annalise, would be, we talked a little bit about educator, like, and pathways to education and training. Another theme that came out in our study, and this was across all three provinces, was the related to training and education. The shift to entry to practice PharmD was seen as a facilitator to uptake of new scope services. And also, though, that we need to remember and support our pharmacy colleagues that still continue to benefit from high quality continuous professional development. And I know everyone here has been involved in that in some way, to support folks as new scope comes in, and also to support our internationally trained pharmacist colleagues that are coming into practice in Canada to support the integration, right? Recognizing that the pathways to a pharmacy degree and what that education looks like is still different, globally. And so those are some of the things from an education perspective, as well.
Yeah. Thanks, Natalie. I think those are great comments to round out the session, and I think that education piece is just so key. And I'm so happy to have you joining us on this panel today. Very, very wonderful. We have about 12 minutes left, so I'd like to turn to a few audience questions now. I'll just read them out, and whoever would like to jump in, please feel free. Katrina has asked, ESDC, apologies, I do not know what that stands for, had funded the Medical Council of Canada's Physician Workforce Database. Are they an exemplar for pharmacy? So I think that question is really around, are there other health professions as well, or examples that we could be looking to for health workforce planning? And number two is CIHI's workforce data set still being revamped, or I think this is the Canadian Health Care Workforce Network, taking this over now?
Yeah, I can
Yeah, thanks.
quickly start. CIHI absolutely has a minimum data standard. The project that I was referring to, Katrina, is a partnership with CHWN and CIHI working on, and that that data standard is updated. A number of professions including pharmacy, contributes into that data set and has for a number of years. And so it's really how to enhance it, how to enhance the minimum data standard that is used in Canada and elsewhere, and to think about it across the healthcare sector too, to other healthcare workers. And yeah, ESTC funded project. I mean, I think that's interesting. Is this an exemplar? And should we have a national pharmacist registry? Yeah, I think there's certainly those that would argue, yes, that could bring value. You know, and that is a step towards having, you know, data on individuals that maps from the point of entry into a program until retirement. Is a national registry can help with some of that. Um, Piece. So there are certainly those that would argue yes. Yeah.
And
I don't know if others have anything to add.
Susan, you jump in.
Okay, either one of us could jump in here to say that, you know, certainly the regulators are very aware, informed about this, and talking about it for sure. Is it an exemplar? Yes, it is. There are a couple different models, and likewise, we recognize that there are certainly benefits to having a database, and particularly to this topic, the potential to be able to track and understand. You know, we don't understand how many pharmacists or pharmacy technicians are working in multiple jurisdictions at any one time. What does that look like? A database would really help us. So to have that sort of unique identifier, and as you've said, Natalie, to be able to monitor that through the lifespan of those individuals as well would be very helpful, and begin to inform us around HHR planning. Beb, you might want to add to that.
No, you said exactly what I was going to say.
That's great. I'm just going to turn to the next comment maybe from Rosemary. I'd like to get the group's thoughts on practitioner confidence and how that relates to increasing consistency for expanded scope activities. Bev, you've unmuted.
Yeah, I'm going to jump in on this one because you're right. Certainly that is one of the findings from the evaluation of our community pharmacy primary care clinics. I would say it's a factor. It's not a challenge. It's not a barrier for sure. It's a factor that we are currently in our work of strategizing a change management plan to support all healthcare, all pharmacists in transitioning to the full scope that's going to be authorized. That's a big piece, is how do we enable them to build confidence? Because what we learned through the community pharmacy primary care clinics is that I don't have the numbers, but you know, they demonstrated that with doing it, with practice, and using that skill to make decisions, not recommendations. So they're making clinical decision making, and then getting feedback on that iterative process builds confidence. And so those pharmacists who participated said with time, with practice, a tremendous increase in their confidence. So it's not a matter often of competence as it is confidence. And so our work is because we need all pharmacists, for the publics to experience consistency and being able to understand what is the care that can be provided. They need a consistent experience when they request care that is provided. And right now, I think one of the biggest areas where pharmacists can and should be really owning this, and I would say this certainly nationally, isn't in what we call minor ailments and common conditions. It's great. That provides access to Canadians for common. It takes pressure off the healthcare system for sure. But in terms of where we really can provide improved quality is pharmacists owning the drug therapy management. And so when we're talking about assessing patients and prescribing ongoing renewals and looking at the labs and adjusting the dose and adjusting the therapy. And so when a patient comes in and says, I need renewals on my medication, and a pharmacist says, contact virtual care and get those done, or let me fax your physician, or go to the ER, we really are missing an opportunity to provide better care to that person. pharmacists are best positioned to do that care. And that is an important area that we're going to be focusing on to build confidence.
Natalie or Susan, any other thoughts you'd like to build on that?
Yeah, I think the only thing I would add to what Bev had to say is, education and training plays a role here in how pharmacists are trained and how, pharmacy technicians are trained, all the training and I think that's shifted a lot in a positive way. So, I mean, entry to practice PharmD is still relatively new, and it's only in the last, few years that we've had consistency across the whole country. So I think that's something that will shift. In our own research, in our interview data, when we were looking at our data, compared to some of the factors that, influence uptake of scope, new scope from 10 or 15 years ago, Canadian data from Zubin, Austin, and others, there were pieces that we didn't see as much in this data set that had been seen previously. And so references to, peer referencing or wanting to see others do it or practice were less in our data set. We didn't see that come up as much. And so I think that actually speaks to a shift in the evolution of the identity of pharmacists, where I like to think the confidence issue isn't necessarily the biggest issue anymore. Not to say it's not there, but I do think that's shifting.
Annalise, if I can just jump back in for 1 second, Susan, when Natalie was talking about education, I think there's a tremendous opportunity with AI and using AI in education modules to create those opportunities for pharmacists to engage in making clinical decisions, getting feedback, being affirmed, being directed. And I think education is part of the strategy 100%, and I think AI can help support that. Sorry, Susan.
Yeah, no, that's fine. And I don't know that I really would have too much more to add. I think just, as we talk about the confidence, one of the things, and I agree, Natalie, I think we're hearing less and less about that as much as some of the other issues that are maybe coming to the fore. And of course, for us right now, it is more so about the practice environment itself and the supports and the resources, and having the confidence that that there's autonomy in the decision making of whether or not to engage in some of the scope, to be able to make that decision yourself, that you're ready to do that, as opposed to feeling like your place of practice is putting it on you, and putting it on you to do it in a way that is perhaps before you are ready with the resources, or that there aren't the resources, and one of those resources even being the time to be able to spend doing these activities. And so, of course, that for us is one of the big things that we are also trying to take a look at. And Bev mentioned that there's work in Nova Scotia. There's exciting work in Nova Scotia in that regard in terms of staff-wise, and I can say that Ontario is watching that very carefully, and in fact going to work with Nova Scotia to understand whether that might even be something that we could take from a small province into a very large one that has a very different ability to perhaps gather some of the data that would be needed for it. But that's just another really nice example of how what can be developed in one province. As regulators, we're excited about and trying to work together to see how we can bring that across the borders.
Thank you, Susan. We have 2 minutes left, so I would like maybe in 20 seconds or less to address Tim's question, which actually takes us a bit of a step back to more of a global lens. Tim asked, do the UN Sustainable Development Goals have any influence on meeting pharmacies' labor force needs, and particularly around access? So curious, Bev, Susan, or Natalie, have any of you looked to the United Nations or other perhaps global examples of how we could be addressing some of the health workforce needs?
I'm certainly happy to jump in a little bit with that, because I am very connected to that, understanding that work. I do some work with the with FIP, the International Pharmaceutical Federation, and certainly that is very important work to what they are doing. And I would suggest that Canada and the regulators actually here in Canada are connected and understanding. And yes, the UN goals, we're a part of that. So I do think that we're looking at it, and I would say, and there's an excellent report that FIP just released this year, their global situation report, which is very much tied to the sustainable development goals with the UN and the numbers, and actually pulls together so many of the things we've been talking about today, and what are the various drivers, the role of pharmacists, the opportunities that are there for pharmacy to be contributing differently, and how that is playing out in terms of supply and demand globally. And just to say that I think they also are doing some excellent work, and have had for such a long time a model that perhaps we need to get better at, in terms of developing approaches that are truly just models that then can be taken into a particular jurisdiction and understood on a needs basis within that jurisdiction. And because they are working globally, and that has to be the way that they operate, it's a little bit of what we're talking about here, that we need to do the same thing. And you know, we can learn from each other, but we recognize that if it comes at a higher level as a model, then we can take that and put it into a needs base. So I think for sure what's happening in the Sustainable Development Goals is something that does apply, and many of us are already looking at it.
Thanks so much, Susan. Well, that takes us to 5 p.m. I feel like this hour just flew by, but I've also been watching Bev and I's backgrounds get progressively darker as the sun sets here with the time change. But I would like to sincerely thank Susan, Bev, and Natalie for joining us today. This was a fantastic discussion on issues that aren't going away. So little plug there for perhaps a future conversation or two on this topic and all of the offshoots of this topic. But thank you so much for joining us. And I'd also like to thank our audience members for joining and just helping us think thoughtfully about this event, both before the event and during. Very brief plug, our last CPE Speaker Series event of the year will be taking place on December 4th, which is a Thursday, 4 to 5 p.m. as well. The topic of that session is on strategic placement and accessibility of naloxone kits in Canadian communities. And ties together a few threads along the lines of artificial intelligence from today's conversation, as well as harm reduction and some other examples from across Canada. So we hope you can join us for that. I'll be there regardless. But thank you again, Natalie, Susan, and Bev, for joining us, and I hope everyone has a great evening.
Thanks so much, Annalise. It's been a privilege.
Thanks, Annalise.
Thanks,
everyone.
Thank you so much.